you.
Well-planned follow-up after hearing all about the private sector initiatives, public-private partnerships, and certainly what some of the wishes were for outcomes from tomorrow, governance and follow-through. And really happy to have such esteemed panelists and representations from government and multilateral institutions to talk a bit about how we can put those into practice, and want to dive right in. So let's go for it. Stewart, it would be great to start with you. I was quoting WHO data earlier when we were kicking off.
Good.
So I'd like to come back to the WHO and talk a little bit about the measure that the WHO adopted in 2015 at the World Health Assembly, calling for national action plans to be instituted. And 4 years later, the Director General talked about the need to push implementation of those action plans. And to throw a data point at you, these exist. There's 180 of them, but only 11% are financed right now, or funded. So tell us a little bit about the progress that has been made, and what are the barriers here?
Well, first, thank you very much, and thanks for including me in this event. I think we have to accept that that is some progress, right? Actually having national action plans. And so there is, I think, there is reason for optimism here, but it is about, ultimately, it's about funding, right? And if 11%, only 11% of the national action plans are funded, what are the odds that the national action plan is really going to result in anything? Look, for example, at training of healthcare workers. They have only maybe 10% of these member states actually have a standardized, developed program for training healthcare workers. Without training healthcare workers, you're not going to be able to address some of the basic issues that are causing antimicrobial resistance: infection prevention and control, water sanitation and hygiene, and so forth. And so I think it is about funding, and it's also about governance, right? And there's a good story there, too, I have to tell you. The quadripartite is strong. It is, in fact, I would tell you, in my experience, which goes back to 2003 with H5, never then was there talk of, consulting with WHO and FAO and OIE and so forth. It was always just WHO. But now it is a real partnership. And that partnership, I think, is the solution. It is the way to drive this forward, to give real meaning to One Health. One Health not as a slogan, but as an actual practice, as an actual institution.
If we could come back to financing for a minute, what are some of the constructs here that are blocking financing? Is it political? Is it financial incentives? What's your take on that?
I think, we have had success multilaterally in working between health and ag and other sectors. I don't think that is I don't think there has been as much progress in member states. And I think that's a big part of it, right? Is working together and identifying the problem, and where the problem is recognized and the significance of it, funding follows. I don't really think that AMR is particularly well understood, right? 3 initials that people are worried about. But really, what does AMR mean? You all know. But if you go out into outside of New York or outside of places that are interested in this, there's not a lot of understanding. In fact, everyone in this room has been impacted by antimicrobial resistance. Maybe a distant family member, but it is serious and it is every day. And I think if people understood that more, the funding would follow.
I would love to just to keep with you for a second here and come back to the quadripartite and the importance of that. The FAO, UNEP, World Organization for Animal Health, have taken a lot of strides on this. What does this mean to AMR? Maybe you could help educate us on that. Why is it important to have those groups working together?
Because decisions made related to animal health affect human health. Decisions made in human health affect animal health, plant health, and so forth. And it's more than just treating a particular disorder, doing something in human health or animal health has consequences, right? And it is, antimicrobials is essentially a code-breaking exercise by nature. The more they're used or overused, resistance follows. And you have to both innovate, but also exercise real stewardship. And I think focus on equity in terms of access to the antimicrobials, but also equity for diagnostics and so forth. It all comes back ultimately, my own view, to, at least for human health, to primary health care, universal health coverage, right? That's part of it. But I also think it is about the recognition of the problem and what it means personally.
Got it. Malin, would love to bring you into the conversation, if that's okay. I would love to hear a little bit, let's get into some of the country approaches, if we would. A little bit about Sweden's strategy, your intersectional strategy based on Well Health, One Health. It combines human, veterinary, environmental care. And you have a low use of antibiotics in Sweden, is that right? Maybe you could tell us a little bit about that and how that's created a favorable situation when it comes to AMR in Sweden.
Yeah, thank you for this question. And of course, I need to start with just saying that we started very long time ago with this work. So yes, we do have a favorable situation, but our first national action plan, which was already then cross-sectoral, that was published in the year 2000. And some of the goals in there are still not entirely achieved. So it also requires some patience. But yes, we do have a true One Health and multi-sectoral approach to AMR. And that, I mean, it requires patience, absolutely. But we invested a lot of efforts and energy into making this intersectoral coordination group that we have a really good collaborating group. And this group is really, it's not only human health, animal health, and environment, but it includes trade, education, research, development cooperation, for example. So it's a true multi-sectoral collaboration built on trust. I think that is something that we achieved along the way, and incredibly important, of course. When it comes to the use of antibiotics, again, we started early. Our national stewardship program started in 1995. And it's the basis for this is the data. So we look at the prescription data, we develop treatment guidelines based on resistance data, and then we have a peer-to-peer approach looking at prescriptions compared to guidelines and adherence, and have these peer-to-peer discussions around this across professional groups, but also with an element of benchmarking. We do publish this data both monthly, quarterly, and annually. So there's also transparency around the entire surveillance. So the benchmarking between the regions, we have a decentralized health system in Sweden. We compare the regions, and
It's competitive?
Yeah, it is, of course. If you publish the prescription for each region openly, that brings in the benchmarking. We also have national targets on prescribing, so we also can measure their progress towards these targets. So it's proven really useful and helpful for us. Of course, this is also a bit context specific, I believe, because in Sweden, we have this kind of broad consensus culture. We have not so hierarchical systems. We can really bring in the nurses, the pharmacists, and the infection specialists in the same group and have these discussions around these topics. And it's a bottom-up approach very much. Then, of course, it's met by the national strategy and the governance that we need from top level, of course, as well.
That's great. And maybe you could just tell us a little bit about the early start it sounds like Sweden got, back in 2000 and even 1995. What's some of the history there? What do you attribute that to?
Well, I would really like to start even earlier because in 1986 we banned the use of antibiotics in animals for growth promotion. And that was based both on what we could see that we had an increase in resistance, but it was also, we didn't have all the evidence there for this decision to be taken, but it was taken with the precautionary principle. And it was very much in dialogue with the private sector and the food producers. So I think that was really the starting point. But in 1995, this national stewardship program that also started from the physicians themselves seeing that we have problems here. We cannot treat our patients as we expected. So it was really a grassroots movement from the beginning, and then after a while, it also gathered the necessary political will from top level, and that's how we continued.
Fantastic. Would love to come back to you and hear a little bit more about a broader European strategy, if you could speak to that also. But I'd love to bring Niall into the conversation. And we've talked a lot about this famed prescription program that the UK has employed, the Netflix strategy. And we promised that we would dig into that a little bit. It's been, how long now? A couple of years?
2 years.
2 years. Would love to hear, well, first of all, and if you could brief us, explain for us here and in TV land a little bit about what that means and what your experience has been.
Yeah, so other streaming service metaphors are available, but Netflix subscription model is how it's often been referred to. I think the previous panelists covered this a bit, but it's essentially the business of trying to de-link the profit element for pharmaceutical companies from the volume required to sell. So obviously with antimicrobial resistance, you're not looking for a situation where the return on investment that a pharmaceutical company can make is tied to how many antibiotics a GP practice, primary care, can push out the door. So in the UK, I think it's back in 2019, we started with a couple of new antibiotics, this subscription model. Essentially, each year the UK provides a certain amount of money to these pharmaceutical companies. They know they're going to get this set amount, and in return we have access to the antimicrobials we need, but only use those, of course, that use them in the cases that we think they're most necessary. So very much kind of following the WHO AWARE model, keeping them on the back shelf for use when other existing antibiotics fail. So yeah, we passed it through our kind of National Institute for Clinical Excellence. It's the part of the UK government that assesses healthcare interventions and decides if they're value for money, having impact. This one was an interesting study because we were not just looking at those who'd received these particular antimicrobial drugs, but also trying to make an economic analysis of those who did not receive them and received some of the more standard pre-existing antibiotics. But we think it's been successul. We're keen to try and roll it out to other drugs that might come out on the market. But I think, as previous panelists were saying, I think the UK, has 3% of the antimicrobial drug market. To really create the added pull incentive, we need to be able to implement that subscription model in a variety of different countries to build up the incentive.
Yeah, and you were just telling me you were about to or have just published a new report as well on
yes,
the success.
If I was the author, I'd be here with my copies to sign. But the UK has also, in the build-up to the high-level meeting, we've published our updated national action plan for the UK. Lots of good material in there, recommitting ourselves to our top aim as a UK government is to contain and control antimicrobial resistance by 2040. That's the target we work to, and every 5 years we publish an updated national action plan that covers the health sector, agriculture, food production, environmental, that sets out the steps we're going to take to get towards that. So yeah, available on the UK government's website. It's inspired by lots of lessons learned from other countries, such as Sweden, but other countries around the world as well.
Great.
Yeah.
What's changed since you last updated the plan?
We've got a lot of, so on the innovation side, we've got some quite exciting stuff coming through. I think one of the things we're particularly grips with is the need for more research on the social and behavioural side of antimicrobial resistance. So I think in the UK, we always naturally thought AMR, R&D, well, that's the discovery of new antimicrobial drugs, and that's absolutely vital, and we need that. But we're starting to hone in a little bit more on some of the behavioural drivers of antimicrobial resistance. So, you know, this classic scene, which we've all had before, where you go into the GP practice, as it is in UK, your primary care physician with a problem, and your mind is already turning to what's the antibiotic going to be that's going to get me out of this? And the GP, the physician, knows that you're probably going to ask this question, you know, and it's all these interesting studies we can do about how you help both professional and patient through that sometimes awkward discussion. So yeah, we're looking forward to setting up what we think will be called the Fleming Centre in London in 2028, which is going to do a lot more of this behavioural and social kind of research analysis, and it's also going to kind of try and do the business to bring in policy makers from lots of different parts of government together as well. So colleagues have spoken about how responsibility for AMR is spread across lots of different government departments. We have that in the UK, of course. We have to try and coordinate across our Department for Development, our Ministry of Health, our Ministry for Agriculture. The new centre is going to try and be a bit of a prototype of bringing policymakers from a range of different backgrounds together in the same place, trying to kind of tackle some of the wicked issues of antimicrobial resistance, both the science, the behavioural aspect.
In some of the rollouts in the EU, different national plans that you've seen and that Sweden has helped with, would be great to get some insights from you on.
Yeah, I mean, the EU just quite recently adopted a new council recommendation that is not a legally binding agreement, but it's negotiated among the 27 member states, and that is not always as easy, even though it's not 193. And in this council recommendation, this was during the Swedish presidency of the EU Council last year, we had specific targets on reduction of use and reduction of resistance. And it was surprisingly easy, I must say, to negotiate and agree on these targets. So I think that's quite reassuring. We talk a lot now about the political declaration, and we still don't know really how we will end up with that. But it was really reassuring to see a new higher ambition and stronger commitments from these member states. I was really happy to see that. Another negotiation that is still ongoing is the huge package of pharma legislation. So that is a different story. It does contain several elements on AMR. We haven't really reached to them yet. This will take years probably, but it does include, for example, as I guess you might have discussed already today, voucher as a type of pull incentive with data protection extension. But in this council recommendation, we actually also already agreed on piloting a similar model to the prescription model. UK has one, Sweden has also piloted one already with a revenue guarantee for access to antibiotics. The Swedish model being a small country with not so much impact on global incentives, we did it for access to existing or recently approved antibiotics. But the same model is now being tested at EU level, and that was agreed last year. So this is starting now. It's again a test. And we will have to wait for the negotiations of the pharma legislation, of course, also to see where we end up on EU level when it comes to incentives and access.
Well, it's great to hear that there's some good EU unanimity on how to move forward, more than we sometimes see with 193 member bodies. But speaking of which, it would be great, Stewart, to start out and chat a little bit about what we hope to get out of these high-level meetings. We keep referring to tomorrow's meeting and the meetings in September. What kind of outcomes would you like to see from these meetings in the high-level meeting we'll have in September?
We want to see targets, right? Commitments made. We want to see an independent science panel created, right, within the context of the quadripartite. And I think anything that is in the political declaration that enables and empowers the quadripartite will be welcome and a sign of real progress.
And that's actually a question that we had submitted early from Wellcome Trust's Jeremy Knox, which was, given the breadth of issues where action is required, is there value to moving towards a target-based approach with regular progress monitoring and follow-up, as we've seen in other areas of health and climate change and the like? And how can, how would we move towards that approach? What kind of declaration would you like to see? Malin, you just talked about the value in Sweden's competitive tracking. Would be interested to go to you on this and understand a little bit more about your thinking on the value of targets. You just mentioned that for the EU as well.
I mean, targets are, of course, amazing to drive engagement and progress, absolutely. When it comes to AMR, it's also incredibly difficult to find that perfect 1.5 degrees targets because it's more complex than that. So I hope we will be able to agree on something. My take would also be, and this I think would be even more useful for actual progress, that is to have countries committing to setting national targets, because then they could be more adapted to context, and I think that could also motivate, or it has to motivate also more of priority setting and again the funding. Allocation of funds for implementing national action plans. So that's something that I really want to see, and then we could join under some more overarching goal or a vision, like effective access to effective antibiotics, for example. So that is also a way to move forward on this. But I really look forward to seeing the zero draft and the hopefully the targets that we will have in there, and hear the reactions from member states.
We'll talk a little bit about zero draft in a minute. How about over to you, Niall? Take us home a little bit on what you'd like to see come out of this, but also, what are the next steps after the UN high-level meeting? What comes after that?
Yeah, I think that's a good place to start, because I think the UK's kind of placing ourselves as ambitious realists is how we're approaching the high-level meeting. We know that we're not going to solve everything in the high-level meeting. It is a stepping stone towards action over the next couple of years. We've got the Saudi ministerial coming up in the autumn and many events thereafter. But that said, we are ambitious for the political declaration itself. It does have to be a stepping stone, and we want to see it be a stepping stone for everyone, not just a selection of countries. So yes, we want to see an independent science panel. We want to see targets, but we want the world to feel like they own those targets. Great if we can get some things in the declaration by September, but we hope the independent science panel will take all 196 member states through the process of developing targets which meet the needs of all member states. So we see that as a priority. We want to see the quadripartite strengthened. Stu's spoken about what good work it's doing, but there's always more to do, and making sure the whole of the UN family is engaged in the effort. Malin has spoken to the need for member states to be able to hold each other to account, to share best practice. We would like to see a kind of framework potentially established around that. But I think first and foremost, where the UK is wanting to see the declaration deliver on access. And I think we've seen in other parts of the global health debate over the last couple of years, don't need to name them all here in the 1 minute that's counting down on that clock, how vital access is and how complex it can become in international negotiations. So it's often a very difficult thing to explain to a minister from my part of the world who's got very used to the idea of how we must not prescribe too many antibiotics. That's the answer to AMR, to begin the process of education that's required to explain and take a domestic-facing minister on the journey of understanding that whilst we're fortunate to have an over-prescription problem that we need to get on top of, vast parts of the world do not even have access to the basic antimicrobials we take for granted. It's an interesting juxtaposition for uninformed newcomers newcomer to GRIP. So we want to see it deliver on access, and I think the only way we're going to solve some of that access problem is really trying to build on some of the reforms that we're seeing elsewhere in the international system. So the big efforts through Bridgetown to try and increase as much financing as we can possibly get our hands on, to stretch the balance sheets of some of the big multilateral development banks, and make the process by which low and middle income countries access that funding an awful lot more simpler than what it is at the moment.
Yes, that's a good point. There is some templating we're doing with in the climate and the environment that can be applied here as well. Well, I've heard a bunch of different great ideas on targeting, all under the rubric of governance, on targeting, on the whatever streaming service you would like to use, streaming starting early, using data, comparative data, making it competitive, and the importance of the quadripartite to keep that going.
I think there's also, in addition to the process that leads up to the political declaration and the high-level meeting, we also have to take advantage of this opportunity to educate and advocate about AMR. As I said, I know that a lot of people in this room understand it, but it is not widely understood. If it were widely understood, if the threat, the individual threat, was known, money would follow. The fact is, I think people think that it is something that happens somewhere else, but it happens in every hospital. And in fact, it happens in the best funded hospitals in the world. They can't even control these things. So it means something very personal to someone who has cancer or a genetic disorder. They're more likely to die of that than they are of the underlying condition, of an infection.
Yeah. As you've mentioned, it's impacted everyone in this room in some
Right,
some
but
shape,
it's
manner, or
not
form.
because it
you're
kills one at a time.
Yeah.
It's not particularly, I think, well understood.
Yeah, understood. Well, it's wonderful that we have so many smart people focused on this in lots of different organizations and countries. Thank you so much for spending the time and sharing that with us. I really appreciate it.
Thank you.
Neil, Malin, Stewart, thank you so much.
Thank you very much.
Thanks so much. Please.
And now, please welcome to the stage Ambassador Francois Jackman, Permanent Representative of Barbados to the United Nations, for his final thoughts on opportunities